next speaker. Our next speaker is Dr. Gangadhar Sundar from Singapore, and sir is going to speak about the pearls and pitfalls in the management of post-traumatic orbital reconstruction.
Thank you, Dr. Saluja. Is my slide visible?
Yes, sir. Yes, sir.
Really an honor to be with you all. I'd rather be there in person. I bring you greetings from this part of the world. I'm going to share my experience on pitfalls and orbital reconstruction with a lot of overlap with what Dr. Allen beautifully elucidated earlier on. These are my disclosures, but there's no conflict of interest with any of these presentations here. So like Dr. Allen mentioned, I'm going to classify some of the pitfalls because we as surgeons, you're right, we have to protect the patient and heal the patient. But oftentimes we end up with errors. And so I'm going to classify them into diagnostic errors, errors related to treatment planning, and finally, most importantly, iatrogenic, surgical, intraoperative, and postoperative complications. So first about diagnosis, you can both underdiagnose and like Dr. Allen mentioned about overdiagnosing these fractures and keeping an extremely low threshold for intervention. He already touched upon the concept of white-eyed fractures, and I completely agree with him. It's not just a matter of what you see in children. Even young adults in the 20s can have this white-eyed fractures. I would not just call it a blowout fracture, but sometimes these are trapdoor fractures, but not typical blowout fractures. And every once in a while, there are missed findings injuries. Gone are the days where you're treating fractures with plain x-rays. You can see the sinus is completely clear. X-ray report said there was no fracture. It was only on CT scan that you're able to see localized hematoma within the maxillary sinus. This is an example of a combined floor medial wall orbital fracture with dystopia, which requires an intervention. Here's an example of another child, very similar to what Dr. Allen said, where nausea, vomiting, monitored by neurosurgeon, CT brain cleared, normal, and CT scan was reported by a radiologist as normal. But what they miss is that little entrapment right over here. The grain echo the finding that entrapment is a clinical diagnosis. You are, as a clinician, should be reviewing the CT scan before you go ahead and managing these patients. Other pitfall we do is sometimes we do CT orbits and diagnose these fractures, ignoring the fact that the patients may have mid-facial, even lower facial injuries as these patients. This is an example of a cranio-orbitofacial injury where you want to be managing these with multidisciplinary teams, not just fix the orbit alone. And we've seen patients where implants have been placed in the orbit, the rest of the face has been destroyed. He already touched about overdiagnosis, keeping too low a threshold. Remember, not all limitation movement is related to entrapment. Post-duction tests occasionally is indicated in the operative, in the clinical situation itself. Here's an example for patient bilateral nasolacrimal duct injuries where these kind of comminuted fractures before the medial wall of the maxilla is mobilized. We prefer to do prophylactic intubation to avoid a post-traumatic dacrystitis. Quickly touching upon pitfalls and timing of surgery, he beautifully talked about how a pediatric fracture should be done as soon as possible. The first question I always ask is, when did he or she eat last? ZMC fracture should be done within a few days, within a week, otherwise it becomes very late. As you can see over here, this is a gentleman who's got a deformity, was referred to us 2 months later with a significant deformity. Going and doing an osteotomy for him is going to be quite challenging for him. Lower fractures, typically a couple of weeks. Again, it can be 1 week to 3 weeks or even 4 weeks based on the symptomatology of the patient. And finally, inophthالmus can be managed at a much later stage itself. So you don't want to do too early an intervention. You don't want to do late an intervention in these kind of fractures. Finally, I'm going to touch a little bit about surgical complications. Be aware, patients can die during your surgery. Patients can go blind to your surgery. It does happen in my hands, and I've seen it around as well. And you can have other complications, but the one complication I'm going to touch upon is diplopia itself. So intraoperatively, again, Dr. Grover mentioned about a problem-related inadequate exposure. You can have bleeding, you can have intraoperative mydriasis, which makes you pause, stop, or even stop reconstruction, and challenges related to implant placement itself. This is very important. I always say the beginning surgeons start off with larger incisions, wide exposures, see the landmarks with your naked eye. Don't depend just on instrumentation because your implant may not go where the implant instrument goes, but you want to see where the implant goes itself. Pay attention to the various structures which need to be preserved. At the same time, make sure that you don't have the assistant avulsing the eyelids and causing an iatrogenic laceration itself. And to me, when you have a combined flow medial wall fracture, traditionally it's a transconjunctival, retrocurricular, followed by a transconjunctival inferior incision of the lateral canthotomy canthalisis. But a lot of times now I'm able to do this with a pure inferior transconjunctival approach itself. So beginning surgeons, transconjunctival inferior plus medial transcaruncular or retrocurricular incision with a canthalisis, but pre-bent implants Even floor medial wall implants fractures can be easily fixed with a pure inferior transconjunctival approach. Is an example of one such patient. Bleeding, be aware, is not just the arterial supply, but it's the venous return, which also keep to be kept to be important, because you may actually miss this intraoperatively and end up with a problem. Here's an example of a young boy who had a medial valve fracture repair. You can see the translucent medpore on CT scan, which is not very visible otherwise, transecting the anterior ethmoidal artery, causing a compartment syndrome. So you had to go back and take out the implant, evacuate the hematoma, and then reconstruct it. The other aspect that surgeons should be aware of is the implant dilemmas and choosing what implant. Are you going to fixate it to the rim? Are you going to just put it along the floor in the medial wall? Here's an example of a patient who had a floor fracture repair done, a silicone block, but the entire deformity was not addressed with persistent herniation and diplopia itself. So basically, what implant to use to a very small fracture or crack fractures, you can probably put nothing, or use sheet implants. But if you're using large fractures, you think about anatomical implants. And if you're doing complex revision surgeries and orbital fractures, you think about patient-specific implants. So here are examples of where implant disasters are seen, partly because of poor visualization, poor technique, poor experience, and poor placement of implants itself. There's a whole variety of implants that's available. It's like going to a restaurant and eating off your menu. You cannot just be familiar with one dish and keep eating the same meal every day. And this is a new generation of patient-specific implants we're starting to use for complex revision fractures. How about postoperative complications? The worst is visual loss. Remember, it's real. Okay, you can have either globe injuries, thankfully extremely uncommon, although if a previously repaired globe can be disrupted, you can reopen the wound, but more oftentimes it's vasculopathy or optic neuropathy. So be aware of compartment syndrome, retrobulbar hemorrhage, subperiosteal hemorrhage. Mr. Rose has talked about the devil's touch, and we've written a major paper on this concept itself, the various mechanisms. It used to be thought as CRAO. It's not the CRAO, but actually it's the posterior ciliary arteries and the finer vessels which are innervating or supplying the optic nerve, which usually are the cause of visual loss. And learn to do not just a canthotomy and acantholysis, but a septolysis as well. But ideally, you want to be preventing these complications. Finally, touching about diplopia, this is the second most dreaded complication, iatrogenic complication itself, knowing the threshold to intervene. Remember, it's not just a muscle issue, but it's an intermuscular septum issue as well. And more traumatic the dissection you do within the orbit, or you incarcerate the intermuscular septum, not the muscle with your implants, can cause diplopia. Here's an example of a patient who's got a simple floor fracture with entrapment and diplopia. Even after 2 weeks, we went and fixed him. We thought we did everything right. And look at him 1 week later, significant hypertropia, inferior rectus dysfunction. But because we were fairly confident, including the post-op imaging showing the implant is a normal place and force duction was intact, we just ended up observing him and returned back to normal itself. So keep in mind that not all diplopia is serious, but you do see these kind of patients who have residual diplopia, who are intolerant to frenal presence, or they have a large ankle, may require strabismus surgery. So in summary, there are numerous pitfalls. Orbital reconstruction can be quite challenging, but if you get it right and know fully well, and you get enough experience and use all the technology that you have, it is very satisfying. Have a methodical preoperative evaluation, have a meticulous intraoperative surgical technique. Remember, people blame implants. It's not the implant, often quite challenging, missing. And finally, every case is a learning case. Don't be arrogant about your surgery itself. The first time is your best time. Thank you very much for the opportunity.